I've also noticed in the last 8 months that he has become slow in walking, uh, and also while performing his daily routine activities. They used to start eating dinner together, and now, like even over a period of time, he used to take more time eating, um, and while walking, his steps had become shorter, and he used to drag his feet, and occasionally would freeze at a place and would uh, take multiple steps while turning. And he had a bent forward posture while walking, and used to hold objects tightly uh, because of fear of fall. There was, but the relatives were not sure of any decreased arm swing while walking. Um, Now he used to thereafter take support of two people to walk, and and uh, had and his body and limbs had become rigid to the extent that even while turning in bed, he turns as a whole. Um, Patient did not have any history of any sway while walking, and there was no history of any weakness of his lower limbs or upper limbs when he was able to walk. There was no history of any slippage of footwear. Um, uh, there was also some history of shaking of his limbs since last 6 months, which were regular at rest and symmetrical. But there was no history of any loss of consciousness or frothing or tongue bite. His handwriting had changed and had become smaller and irregular, because of which some of his checks were rejected since the last 3 to 4 months. His wife had also noticed irregular jerking movement of limbs, um, which occasionally awakened him from sleep, and they were more frequent during the night. And the frequency has increased from 2 to 3 times a day to now 30 to 40 times. But there was no history of any loss of consciousness, tongue bite, or frothing. Um, um, Occasionally, he used to scream at night while sleeping and move his legs, um, and do irrelevant talking. But there was no history of any seeing any unusual person or objects in his environment. Patient has now become lethargic and usually sleeps the whole day and does not interact or ask for food. Um, he's inattentive and is unable to speak. Uh, he hardly utters a word or so, and he is not able to understand commands. So should I go to negative history?
No need. You can discuss the history. Then we will go.
Right, sir. Sir, the initial problem which started was of the
Back to go back to the slide first. Shwet, I want to ask you one question. Is this the way
Yes.
you people are presenting that by lobe or the symptom progression wise? How you
Sir,
people?
sir, last time, like when I think Dr. Rama had presented that time, sir had said that you present by lobe.
Okay.
So,
This is the way you people are going to present in the exam.
sir, um,
What we people used to present here is we people go in a progressive history wise manner, because which symptoms start first and then we go by that symptoms wise. That will be much easier, no? for the symptom localization. Because as we all know, Alzheimer's starts memory problem, recent memory problem. It will progress further, and you can involve any other lobes, and you can have further lobe involvement and further symptoms. But other like TLBD starts more with the visuospatial and other symptoms, and memory will be affected bit late.
Yeah, better to go ahead with as
But to
the
go with the symptoms like
progression of illness.
Right, sir.
progression of symptoms, that will be better, right? Anyway, you discuss like this.
Right. Sir, the initial problem which started was that he had difficulty and navigation. He used to forget his paths when he used to go for walks. So
Parietal,
yes,
next
sir.
slide.
Yes, sir. Then the next, this was the topographical disorientation, which
Like
was
you go to the history description, because we want to see the history.
yes, sir. He had like difficult, like first was that he used to forget his path, and the second was that inside his home he used to forget. He used to go to the washroom and the balcony instead of where he wanted to go.
What that symptoms suggest you? Sure.
So the topographical disorientation.
Visuospatial, more of a visuospatial or topographical
Yes,
diagnosis.
sir.
Yeah.
That will be
Where is the
localized.
localization?
Yes, sir. Localization, sir, was right parietal lobe, sir.
Right parietal. Okay.
Yes. So then,
So, like initially, he had a visuospatial disorientation outside home.
yes,
Usually,
sir.
it's that only in unfamiliar places. It starts in the unfamiliar place first, and it will progress further, and it will involve the familiar places as well. As you mentioned, like he misses his bathroom and go to kitchen. Does he urinate there?
Then, not initially when he had awareness, he would not do that. But that has started happening the last 1 to 2 months.
When he misinterpreted, he more likely chance for urinating there, no? And how you gonna understand that it is not bathroom, it is kitchen and all? Whether he is able to go to the bathroom himself without any help.
Um, so, like initially, he did manage to go, and he was like when he used to go there, then when like the people working there, they used to probably ask him, and they would say that this is if you come to wash hands, then or you have come to urinate, then you should go to the bathroom, and you come to the kitchen. That is probably he must have.
So he needs assistance. Okay.
Yes, and he had to be told that the location wasn't correct.
Okay, continue.
So then the next symptom was that he that was about 5 months earlier was that he would had difficulty in wearing his shirt. He used to put his hand in the opposite sleeves. That would go to sort of
But
again
that,
dressing apraxia, sir.
anything else is possible rather than dressing apraxia here?
It's, sir, mm,
Whether he is able to put the shirt,
he was able to, yes, sir.
able
Like
to
if
wear
you, but like if you like corrected the sleeve, and he was able to do it. He was able to
what
button,
buttoning,
yes, yes, sir.
whether he is able to button himself.
He was able to button, sir, after being like after the sleeve was corrected. He was able to he managed to button it.
It could be part. I think you should elaborate more on the history. Whether he is able to put it correctly, whether he is able to take out the shirts, can orientate it properly. is able to put the shirt and all. Then only we can differentiate it from the executive dysfunction. It can also happen with executive dysfunction. Patient with executive dysfunction also won't be able to do these acts.
Okay.
Okay. Continue.
Sir, then he had difficulty in handling the money and was not able to calculate the money which was supposed to be issued for these insurance policies. So that I took that as a calculator and attributed it to left parietal lobes.
Parietal, which area? Specifically, which area?
Calculia is um, fusiform gyrus.
Fusiform gyrus.
Uh,
Where is the fusiform gyrus situated? Shape.
it's between these are supra marginal and
I think you should not put this thing here. I calculate left parietal on the. You should put by discussing. You tell rather than writing here, because other people are seeing the slides and all. They can't discuss. They can't think. They won't think out of box. That is a problem.
right.
Next time when you present, don't make ideomotor apraxia, drifting apraxia, alkaline. Don't write those things. Left parietal, it is more angular gyrus. Okay.
Right.
Left
Right.
parietal, how many parts are there for the parietal?
Parietals are
Superior parietal and inferior parietal. Superior parietal lobe and inferior parietal lobe. What are the parts in inferior parietal lobe?
inferior parietal lobes are supramarginal gyrus and
And this angular gyrus. Okay.
angular. Yes.
These are the parts of the inferior parietal lobe. And the angular gyrus is the one responsible for the calculation. Okay. Continue.
So then, then the next activity, the brushing the teeth, he used to, even after being demonstrated how to perform, he was not able to brush his teeth and would just hold the brush in his hand and stare at it. So
Yes. What is it suggestive of shape?
yes, sir. I put it to sir ideomotor apraxia, sir.
Not ideomotor apraxia. What is ideomotor apraxia?
Sir, the inability to perform that motor task.
Yeah, define apraxia.
Yes, sir. Inability to perform the learned motor activity with preserved motor, sensory, and visual
Coordination, comprehension,
coordination and comprehension. Yes, sir.
other things.
Yes.
So what is what is history? When we get the brush, when you get the paste, he just stare at it and he does not initiate, even doesn't initiate an act. But it suggests you rather than apraxia. Ideomotor apraxia people will do and they will make the spatial and temporal errors. And they won't be able to pantomime to verbal commands. They won't be able to imitate the gestures. They don't know the gestural meaning. But they will do the acts, but they will make the spatial and temporal errors. They will hold the tools in a improper manner. They will make errors in timing of the use of tool. All those.
Yes. This
more
could be
executive dysfunction rather than ideomotor apraxia, because he doesn't know how to do it. He just stare at it and he just
yes. The executive.
more suggestive than executive dysfunction rather than ideomotor apraxia. Dr. Mohan, what do you think on other moderators here? Mohan Bhushan.
Yeah, Dr. Bhushan and Dr. Mohan can join.
Okay, we'll join. Okay, you continue, Shvet.
Yes,
So
sir.
more
So
executive dysfunction.
right.
What
So
are
when
the parts of the executive function? What are the executive functions, Shvet?
executive functions are planning, then set shifting, and uh, social cognition, and initiation.
Only tell main four things. At least main four things you should say. Planning is there.
Yes.
Responsibility is told. What are the others?
Um, self inhibition, sir.
Inhibition you told, no?
Yes, sir. Um, uh,
Fluency,
fluency,
here,
yes, sir.
fluency, working memory, set
Work.
shifting, and response inhibition. Set shifting, response inhibition, working memory, fluency. You can also tell planning. This much you should tell when you asked about the executive functions. Okay.
Yes, sir.
So to do an act, you have to plan how to do, how sequentially you do. For that, you need executive functions.
Yes, sir.
In executive function abnormality also, people can have these problems. They'll start looking at this, stare at the objects, stare at the things they have. They won't do.
Yes, sir.
Okay.
So next symptom was that he used to get confused while doing physiotherapy, and would mistake his right side and the left side. So I took that as right left confusion, and that was the left parietal lobe, sir.
It an attention problem, or he consistently make the errors, or not he make the errors.
Um, he like not consistent, sir. Occasionally he used to get confused
Okay.
when it started.
The attention problem as well. Rather than like the confusion, you can put it as an attention. You don't discuss it that it is more of a right left confusion. When you discuss, you should be open rather than okay. Should be
Right,
open.
sir.
Discuss the possibility, and out of this more suggestive of this, you should only tell that. Can be right left confusion, it can be due to attention problem. Okay. And
Right. So then the next thing was that he had uh, occasionally deposited money twice in the issued money twice for the policy, the insurance policy, and also he had visited his relative, which he had forgotten, and was asking his family members to again go and visit. So both of these instances, I take that as the loss of recent memory, sir.
when this started, when this memory
This,
problem started,
sir, like started about sir, about a year back, sir. This memory problem
both
started.
started the same, that visuospatial and memory started together, or visuospatial start first and then the memory.
This is
Sir,
the most. I think this is why sequencing the history is very important here. Actually, so
Is
I don't know, but
very difficult
the
to
way,
discuss. Oh,
yeah, it should always be in the order of involvement. So
memory started earlier, sir. Later, this parietal started, the sequence, the visual spatial started.
okay, you continue.
So then, over the time, he started forgetting what he had eaten, and uh, thereafter he would also, when asked that where his daughter lived, and like her birth.
Okay, suggest you. Hello, Sheth? That memory problem suggests you what?
I think
Yeah,
he's got
that is
disconnected.
What disconnect?
Just I'd like to add one point, sir. Actually, this initial difficulty in losing way, I think it could even be a problem of navigation, sir. So
Yeah,
it's just a add-on point. Like whatever I've read from Madhu sir's book and Anand Kumar sir's book. So actually, they say this navigation is specifically a function of this hippocampus and this retrosplenial cortex. So
yeah,
this is what I remember
yeah,
reading. So it's always like better to
yeah,
offer
yeah.
DBs like so hippocampus
Yeah,
and
you
this
you should be
retrosplenial
open.
should also be yeah. So it's always better to be open.
Is better rather than concluding first. Better
Concluding on
openly
one
discuss
yes,
and okay.
yes, sir. And one more, I think Shvet had written about this brushing as ideomotor apraxia, but I don't know whether more of executive dysfunction as you pointed out, sir. Actually, so
Yeah, yeah.
uh,
It is more of an executive function rather than item.
so, how
Problem
exactly
of
like by
presentation.
history? I think he has told they have given prompting, but still he was not able to do. So that is against ideomotor apraxia or so usually they say if it is like the patient has to open the brush, I mean the paste, and then put it on the brush and then start to brushing, that becomes an ideational sort of test for an ideational apraxia. If the patient is given the brush alone and asked to
Yeah,
brush the teeth, it becomes a test for his ideomotor, either a disconnection or a parietal variant.
okay.
So
Yeah, yeah.
here I don't know what exactly was trying to imply. But, imitation of gestures is also lost in both ideomotor and in parietal and disconnection. So
That
so
is.
I think it's more of an
But
executive rather than
knowledge about the gesture will be preserved in the disconnection.
ah, yeah, yes.
That is the difference between the disconnection and
Ideomotor disconnection. Yeah.
ideomotor
Imitation of
disconnection.
gesture is lost in both, sir.
Both
Yeah.
the knowledge will be written. That is the only difference.
Gesture knowledge will be retained, but imitation of gestures will be lost in both. Yeah.
Yeah.
Uh, should we ask someone else to just analyze the history, sir? If Shvet is not it,
Yeah, that we can try.
I don't
Where
know
is Shvet?
when Dr.
If
Shvet is.
anybody want, they can
If anyone
raise their
can
hand.
volunteer to
Discuss.
If anybody want, they can raise their hand in this chat setting. More.
Yeah. Anyone else? I think Telugu sir, you called someone else. That will be better.
this is just a practice. So
Any exam going batch, they can raise their hand and they can analyze.
I think
The
if someone
golden
comes sooner, the better for everyone because
Yeah.
I think yeah.
Otherwise, they
Time
will leave. Better. We'll continue with.
Shwet is back.
Sorry, sir, the electricity problem here, sir.
Shwet, you what that memory problem suggested, Shwet?
Yes, sir. So the problem had like progressed from the recent memory.
Go up.
Yes.
Go up, go up. We only discussed up to
Yes, sir.
Hello.
Yes, sir.
temporarily. What that initial memory problem suggests you?
Initially, sir, like when he used to forget the checks which he used to issue and the relatives the visits. So that was indicating the recent memory problem.
Recent episodic memory.
Recent episodic memories. Yes.
The localization for recent episodic memory.
Medial temporal lobe, sir.
Medial temporal.
anterior.
What are the types of memory?
Types of memories are the immediate memory and then recent and remote. Then episodic, semantic, then procedural, and
Classify like that. You can either classify by the short term, long term, immediate memory, or either as explicit memory, implicit memory, or as working memory, semantic memory, like that, procedural memory. Okay.
then the next symptom, which was that now he was not able to remember what he had eaten, and would also forget the marriage dates and birth dates of his relatives. That showed that probably now his remote memory was getting affected. And
You scroll down.
Yes, sir.
Where is the localization for remote memory?
Sir, the neocortex, sir, and temporal lobes, sir.
So when you tell this, actually it's very important to give the timeline. Actually, that is why going in the chronological order is very important, because there will be a long gap between the onset of your recent memory and remote memory loss. Because only if the disease becomes very much widespread, they'll have remote memory loss. So it's very important. They may actually expect that.
How will you store the memory? What are the stages of memory?
Sir, yes, sir. So registration, and then encoding, and then storage, and then retrieval.
What is the first consolidation?
Yes, sir. Over after storage, sir, the memory gets consolidated with repeated use, sir.
The consolidation occur where first? In case of episodic memory, where it is consolidated?
In the sir, it gets consolidated and stored in the temporal cortex, sir.
Medial temporal, which part mainly? In the which circuit? Which circuit is involved for the episodic memory, recent episodic memory? Which circuit?
Sir,
You know
the
the
anterior temporal,
paper
sir.
circuit, you know. Paper circuit. It is the hippocampus which is responsible for the consolidation of the recent episodic memory. Okay. Describe the paper circuit. The parts.
Sir. Yes, sir.
What are the parts?
The hippocampus is connected to the, sir, anterior thalamic nucleus via the
Hippocampus to the anterior thalamus. In between which structure?
via the sir, this fornix and
Via fornix, where it goes first?
via the fornix, it goes to the, sir, mammillary bodies, and through the mammillary bodies to the anterior nucleus of thalamus, and from there to the cingulate cortex.
From there back to
the hippocampus.
Actually, memory, when we see it is a memory which stored, which comes from the cortex. No, we see so many things from different cortex: visual, sensory, motor cortex, and all. And the memory which is gonna store, which comes to which part first? It goes to the cingulate. Cingulate. Okay. From the cingulate cortex, it goes via the cingulate bundle. It goes to the parahippocampal structure, hippocampal and endorenal cortex, and from there it goes to the hippocampus. And the consolidation of the episodic memory occurs in the hippocampus. From there it goes to the via fornix it goes to the mammillary body. From mammillary body via mammallar canal tract, it goes to
Anterior nucleus.
then posterior cingulate.
Yes. Then there was another symptom of inability to recognize distant relatives. Last 6 months or so. Sir, I think that this was probably because of
In this slide, please. Share.
yes, sir.
Okay.
Sir, yes. So I think it was because of the inability to recognize the faces. It was prosopagnosia. Yes. Sir. Patient was a very interactive person. So he had
No, where is the localization for prosopagnosia?
fusiform gyrus, sir.
Okay.
It's the fusiform
Because you've
gyrus.
written bilateral temporal here.
Oh, yes, sir. That was like I had written this sometime back.
Where it's situated, share. Fusiform gyrus.
Fusiform gyrus is, sir, like this is in the left left IPL. It's near left IPL, the parietal lobe.
Parietal lobe. Fusiform.
Yes.
It is actually present in the occipitotemporal strip.
Yeah. It's mainly in
That's
the
where it is there.
occipital.
So actually, the prosopagnosia, I just like to add a point. So there are two centers actually is given. I think in Madhu sir's book or in James Sir's book. So they've said that anterior temporal also has a role. So both anterior temporal main area is actually fusiform, but actually anterior temporal also has a role in prosopagnosia, and also the posterior visual association cortex also plays a role. So all these 2 or 3 areas may play a role. Just adding on that. Thank you. Continue.
Sir, then the patient was a very interactive person, so he had stopped interacting and stopped watching movies and used to remain silent. So I took this symptom as an apathy, and localization was uh, this left medial frontal. Yes. Then there were episodes of bedwetting with unawareness since last 1 month. So urinary incontinence, I again put this to left medial frontal.
Okay. So
Yes.
so you're telling it's a type of neurogenic bladder. So what type of bladder we get in this frontal, like frontal lobe? Disinhibited bladder.
Disinhibited bladder. Sir.
So how is it? How is the patient typically after? What is the history like typically? You told.
He was just lying in urine, sir. He wouldn't
Okay.
call anybody,
Okay.
and yes, sir. Then the next history was that he had stopped planning things and his visits and making lists, which he used to do. And his cupboard and his items were in a shabby state. So he had stopped organizing them. So this was put to planning and executive dysfunction. So then there were episodes of irritability and amusing his relatives, but no socially inappropriate behavior. So I did not. I don't think there was any involvement of orbitofrontal. It was just probably because of executive dysfunction.
Okay. Abusing in hyperactivity is usually a disinhibited behavior, right? Like usually.
But
There is
occasionally,
no.
sir, like these patients who are uh, forgetful, they
Okay.
you know,
Okay, I think you can offer always like possibilities. Like you can tell, because yeah, you can tell it is because they are aware of their present inabilities and they are irritated, or it could be due to orbitofrontal cortex. So it's
yes, sir. That is another possibility. It could be, yes, sir.
always better to offer, like you don't know their mind. So when you give DDs, it's always like you're trying to pinpoint at some part of their thought process. So it's always better to offer DDs in the exam. So whatever are the possibilities, you just tell, so that they'll also know that you're thinking all the possibilities, and they also will be not questioning you why you didn't think all these things. So always better to offer the possibilities. Okay.
Yes, sir. Then uh, in the extrapyramidal symptoms, his wife had noticed that he had difficulty in performing activities. He used to take more time eating food, and while walking, his gait had like he used to take
Okay. So that is
shots.
Yeah.
that
Okay,
is
Dr.
Was
Shvet, can you summarize the case?
yes, sir. Sir, my patient is a 78-year-old male presented with insidious onset, rapidly progressive psychomotor decline in the form of forgetfulness, behavioral issues with slowness in activities, rigidity, tremor, and myoclonus, and sleep behavior disorder with sorry, bladder and bowel unawareness.
So usually this myoclonus, how will you approach actually when they ask you to analyze myoclonus? Like you directly gone as like
Sir, like the myoclonus, whether it was stimulus sensitive, whether it was more during the sleep, and
so.
whether it
So
was
usually look at
associated.
the myoclonus which is similar sensitive.
So the example of stimulus sensitive, sir.
Yeah, similar sensitive myoclonus.
Yes,
Can
sir.
you
The
give?
yes, sir. Progressive myoclonic epilepsy, sir.
Okay, so they are usually photosensitive.
Yes, sir. Photosensitive and the tactile and yes, sir. Proprioceptives.
Okay, the any sound sensitive myoclonus, you know.
Sound sensitive, sir.
So
Auditory, yes,
so
sir.
okay, so brainstem myoclonus, your startle. Okay, that is a typical example for sound sensitive myoclonus. And then action sensitive myoclonus.
Post hypoxic, sir. Hypoxic,
Yeah,
yes.
post hypoxic. So post hypoxic Lance Adams, chronic post
Yes.
hypoxic. Okay. So chronic post hypoxic Lance Adams, action sensitive. These are some stimulus sensitive myoclonus. Okay. And how will you classify myoclonus based on the area of involvement of body? Like
Sir, like uh, if there is a associated loss of consciousness, then it could be a cortical, or there's tongue bite or
no,
frothing.
I'm just asking about the area of involvement. So focal, segmental, multifocal, or generalized. So commonly this is how it's classified, right? Like
Yes, sir.
so each one has its own significance in localization.
Yes, sir.
Uh,
Sir, the symmetrical axial myoclonosis could be brainstem or the propriospinal type.
okay, very good. Okay, so predominantly axial myoclonuses are either from the brainstem or from the spinal myoclonus.
Yes, sorry to interrupt. We have only 15 minutes time. So for today, you better close at the etiology level only.
Okay, okay. I think we are just
We'll
discussing.
discuss
Like, well,
examination in the later part. right? Carry on.
Yeah, you can just go into the possibilities. Like I think we are just getting stuck with myoclonus. I thought I'll just have a small discussion, but I think there's lack of time.
Yeah. I think there is some connectivity issue with Dr. Shvet.
Yes, sir. He's lost connection, I think.
Yeah. Dr. Ayush, are you there? Okay. I think there is some electricity problem.
If anyone else would just, I think if they've heard the
Dr.
stories,
Dr.
they
Ayush
just
or Dr. Seema or Dr. Arun,
yeah,
can you unmute yourself?
just
Exam
discuss
going
the
back.
possibility.
Dr. Aarti,
Sir, I would like to join. Sir.
yeah. Can you
I'm Arun.
summarize? Can you read the summary and give some
Yes.
localization?
So
Yes,
just
sir.
introduce yourself, doctor, please.
Yes, sir.
Now,
Sir, I'm Arun, sir. I'm from KIMS Hospital, Secunderabad, Hyderabad.
okay,
I'm final year dean resident. Finished my theory exam.
okay, please just discuss about the possibilities.
So, sir, this patient had a progressive decrease in cognition. Initially started in the visuospatial or navigation issues, and then he had involvement of other lobes like executive dysfunction and decrease interaction with the family, that is frontal, and occasional episodes of aggression, maybe orbitofrontal, and along with that he had memory issues, both initially with the short-term memory and then even the long-term memory, and along with that he had extrapyramidal features, that is tremors and myoclonus. So the lobes involved are initially parietal, then frontal and temporal, or parietal followed by temporal and frontal, along with the extrapyramidal. So, sir, hello.
Yes.
Yeah, go ahead.
Yes, sir. So right now the patient is
the myoclonus is localized to basal ganglia.
no, sir. No, I mean I am saying that this patient had myoclonus. I don't know.
Okay.
I don't.
So it could be either a cortical myoclonus or it could be subcortical myoclonus. Right?
Yes, sir.
Okay.
Right now the patient is in major state of major cognitive disorder, advanced stage, and because it has started in the parietal, in the visuospatial and memory. I would keep the etiology most. It is looks like a neurodegenerative because slowly progressive and over years, and
But it is rapidly progressive. It is saying.
so 2 years, but actually
I think he told 1 year or 2 years.
yes, 2 years, sir.
2 years. Okay.
Yes, sir. Or it is or still I would keep neurodegenerative and also rapidly progressive, sir. Even neurodegenerative can sometimes progress rapidly.
So here, so you're telling it's like so. What is the when you have a patient with dementia and myoclonus,
Yes,
and also he has extrapyramidal symptoms, right?
yes, sir.
What are the possible etiologies you'll think of?
I'll think of corticobasal syndrome and CJD, sir,
Okay.
and frontotemporal dementia. I mean, the next node.
So can you get? So you're thinking of FTDP, frontotemporal dementia with Parkinson's.
Yes, sir.
Okay. So can you get myoclonus in Alzheimer's?
In advanced stage, possible, sir. I mean,
Okay.
But 2 years, I mean, like if you progressed, it has become literally bedbound in Alzheimer's.
no, sir. That's why I have not put that is even further down in the order. Sir. My differential diagnosis.
So what is the point against, for and against for each of the condition you told above? CVD,
Uh,
CJD, FTDP, AD, whatever. Like just tell what are the for and against points.
Sir, for corticobasal syndrome, I would expect initial symptoms would be more of uh, apraxia or executive dysfunctions. I mean, like more of apraxias, or and myoclonus a little earlier, and uh, and memory in the later stages. And for CJD, I would if it sir, hello.
Yeah, go ahead.
For CJD, I would be expecting myoclonus a little earlier and visual symptoms. And
Okay, and there will be significant.
sir, apathy. Sir, I couldn't get you. Sir. Hello. Hello.
I can
Hello.
hear you, but I can't hear the seniors.
Yeah, Dr. Shvet,
Yes,
what were your possibilities?
sir. The the structure involved, the etiology, sir. My possibilities are included. First of all, I took metabolic B12 and then the infectious, the viral infections or tuberculosis, uh, then the autoimmune encephalitis, and then degenerative had this prion disease and DLB. Also, this the vascular dementia was another possibility.
Okay. Okay. Can you go for what were the positive findings? Only positive findings in this case, on examination.
Yes, sir. So the positive findings, the eye blink was reduced. The patient had a masked appearance. There was psychomotor slowing in the form that there was reduced motor activity. Patient and the single word comprehension was not there, sir. He was able to name, and um, then he was able to repeat words. Forward, there was reduced attention that he had forward digit span of 1, and the frontal release sign, glabellar tap was there. Then he was not able to perform parietal functions, and clock drawing he was not able to do.
Okay. Okay. Can you summarize your findings on examination and localization?
Yes, sir.
What are the positive findings and localization on the basis of examination?
Yes, sir. Sir, the findings, sir, they showed that he had the executive dysfunction, and parietal executive and extrapyramidal involvement, and even the language was affected, and that could also be because of impaired attention. And also the, I mentioned extrapyramidal system, sir.
Okay. Okay. Can you summarize the whole case and can you give some differential diagnosis?
Yes, sir. Sir, my patient had insidious onset, rapidly progressive this psychomotor decline with Parkinsonian features and myoclonus. Um, the
Okay. Differential diagnosis.
So differential.
What is the rapidly progressive dementia?
Rapidly progressive dementia has features of worsening of predominantly memory and other functions over a period less than 1 year.
Okay. Okay.
Yes.
And in this case, it was rapidly progressive, or it was 2 years or 1 year?
So the history is about for 1 year, sir.
Okay. So what will be your DDs and in which order? Like what will be your first DD here?
Sir, I would consider first would be probably prion disease. Sir. Then next would be this.
So CJD, which type of CJD you think here?
Sir,
So what are the types?
it's a sporadic variant and familial. So this could be sporadic variant.
Okay. So variant CJD, what is the main feature?
Variant has a slower course, sir, and it evolves.
Psychiatric ataxia, psychiatric manifestations, painful feet, ataxia. So
Painful, yes, sir.
okay. So
Attacks.
okay.
Then the other systems, parietal, temporal, and frontal, were also involved along with the extrapyramidal in my case.
Okay. What are the differential diagnosis for this dementia with extrapyramidal symptoms affection?
Yes, sir. So dementia with extrapyramidal symptoms. First is some subcortical dementia, which could be like HIV. Then vascular dementia.
Okay. So dementia with extrapyramidal could be either a Parkinsonism associated dementia or it could be some other movement disorder associated dementia. So both come under extrapyramidal. First, you can tell the Parkinsonism associated dementia symptoms like PDD, DLB.
Yes, sir. The DLB and CBS and PSP.
Okay. So all these things can cause Parkinsonism associated dementia syndromes.
Yes,
And what are the other extrapyramidal or hyperkinetic movement disorder associated dementia? Huntington's disease.
Yes, sir. Then the
Where
Huntington's is there, sorry, sir.
chorea acanthocytosis disorder.
HIV.
Yeah, HIV can cause both dementia and extrapyramidal akinetic rigid syndromes. Okay. And your acanthocytosis, right? So MVA, all these things can cause. So extrapyramidal associated dementia, either hyperkinetic or hypokinetic movement disorder associated dementia syndromes. Okay.
Yes.
Dementia with myoclonus.
Dementia with myoclonus,
Or cognitive decline with myoclonus.
yes, sir. It could be like a degenerative condition. It's inherited degenerative condition with progressive myoclonic epilepsy.
Okay.
Or,
Progressive myoclonic epilepsy. Can you name some pro-PME syndromes?
yes, sir. With this Ulrich Lundberg disease, sir, and
Okay. commoner in India?
Sir, Niemann-Pick, in
Okay, okay,
type C, yes, sir, and
okay,
Tay-Sachs and sialidosis.
okay. Sialidosis. Okay. What is peculiar sialidosis that you don't get in others? NCL and sialidosis.
Sterylate
Sterylate.
spot, sir.
Okay. NCL, what is something that is you get retinopathy, right? NCL. Okay. So you can get both adult and infantile juvenile variants. Because even though adult is rare. So okay. Anyway, other dementia and myoclonus, cognitive decline in myoclonus.
Yes, sir. DLB, then CBS, PSP,
Okay. SSP, again
SSP, yes,
cognitive
sir.
decline. Okay.
Yes,
What is
sir.
the peculiar feature of myoclonus in SSP?
Sir, it is a slow myoclonus.
Okay, slow myoclonus. Okay, and it is usually trigger locked with the EEG
Yes, sir. It's
cerebromotor.
locked. Yes, time locked. Yes, sir.
Okay, time locked. Okay, okay.
Okay, any student is having any question? We have 3 minutes.
Sir, in untidiness, where to localize, sir? That is for in the frontal or apathy or anything else, sir?
Untidiness is usually actually like the patient is not welcomed. That means it's usually a frontal lobar dysfunction. I don't know whether to localize it in a medial or orbital, but usually it's a frontal lobar sign. So if you ask me more specifically where it is, I'm not very sure. Usually, when the patient is unkempt and is not very neat, and that is a sign of lack of insight usually. So, patient is not aware of his own. So that's usually a frontal lobar behavior.
Okay.
Anybody else?
Sir, and one more doubt, sir. When you said in the initial difficulties in Alzheimer's disease is a difficulty in wayfinding. Then you said it is more of navigation difficulty rather than visual spatial. What is the difference between visual spatial and navigation, sir?
It's actually if you read about this, there is Madhu sir's book actually. So they say there is topographic Okay, so they say topographic. So they say, and also James Joseph's book also says there are 4 types of visuospatial orientation difficulty. So
Yes,
if
sir.
you read about it, they'll give like heading disorientation
Yes, sir.
and heading disorientation and anterograde difficulties. That is, anterograde difficulties basically difficulty in finding path in new areas. So that is actually a role of parahippocampus, they say. So when the patient goes to a new area, he is not able to localize which is which. That is the role of parahippocampus.
Okay,
Heading
sir.
disorientation, basically he doesn't know where to go in a even in an old location, he doesn't know where to go. So
Oh,
that is one thing. And navigation, they say usually it is it's given as I think hippocampus and retrosplenial cortex, if I'm not mistaken.
okay, sir.
So one more type. I think some landmark,
Yes, sir.
landmark disorientation.
Yes, sir.
So I think there are 4 types actually. But whenever usually this, it's always better to give us a DD. So
Okay.
whenever a patient loses his ability to come home from somewhere, it could be a navigational defect or it could be a visuospatial difficulty also. So always better to say both. So
Uh,
navigational usually goes to the medial temporal hippocampus and your retrosplenial cortex. Visuospatial usually goes to your dominant, non-dominant parietal.
okay. Sir, and one more last question. Sir, can we differentiate? From history, should we identify it whether ideomotor apraxia or ideation apraxia, or is it enough for apraxia?
I don't know. It's very difficult actually. I don't know how to differentiate between ideomotor apraxia, ideational apraxia, and executive dysfunction. So
Yes.
I think it's always better to offer TDs. But whatever Shvet told in this history, Dr. Shvet told in this history, he told one specific point, I think, that the patient was given cues as to how to do, but he was not able to still do it. I think that goes more for an executive dysfunction rather than an ideational or an ideomotor apraxia. So when you are offering a gesture So that is imitation of a gesture, what he told, similar. So when you're offering a gesture and he's not able to do, I think that actually rules out most of the apraxia. So I think it goes more in favor of a executive dysfunction.
Okay, thank you, sir.
Yeah. Thank you, Dr. Shvet, for
Thank you,
nice
sir.
presentation, and Dr. Mohan, Dr. Mohammad, Dr. Ramakrishna for nice organization and beautiful this presentation. Thank you very much, everybody, for participation. Thank you. Thank you, Dr. Ramakrishna.
Yeah, Dr. Datta, last question. Usually you present case like this, or you prepare for the sake of discussion, like lobe wise. I think the same question asked by the Muhammad sir.
Yeah. Better to go as per the complaints and present.
Your arrangement is very nice. I appreciate that. For the sake of discussion, your PPT or PDF is very useful. But present like a exam. Yes.
Yeah.
Right. Nice PDF for the exam going batch. Thank you.
Thank you very much.
Okay.
Thank you, Dr. Mohammed.
Thank you.
Thank you, sir. Thank you.